And I think everybody's on the Eastern Standard Time. So good afternoon. And I'm Gina Sharps. I'm a dental hygienist at Marshall University, otherwise referred to as one of the tooth fairies. There's 4 of us dental hygienists on the oral health team, and it's a pleasure to be here with you all this month. Oh, and what am I doing for Halloween? I too really don't, we're not big Halloween celebrators, but I do buy the candy and eat it.
You don't give it out, you just eat it.
Eat it. It's horrible.
All right, well, I think we're ready to get started, and we thank Gina so much for being available to serve as our guest speaker today. And as she said, she'll make the PowerPoint available after the presentation, and Sheila will send that out, and I'll post it on YouTube. And would you like it to be interactive, Gina?
Oh, that would be great. Yeah, that would be wonderful. So we don't have to stop, we don't have to go through and wait till questions and answers at the end. If someone, wants to raise their hand or chime in, please do so. I probably should say this too. Let me see if I can advance let me figure out how to advance my slides. Hang tight here. Hey, oh, there it is. Okay. Full disclosure, this is not my first rodeo with oral health coalitions. There you can see I've done some, I don't know if there's anybody in these pictures that are on the call, but for the last couple years, Dr. Crespo's had me take the oral health and diabetes show on the road, and I've done some education in the past. I know on the lower right-hand side, that was in Ohio. In the middle, Sheila, I think that was no, that was Prestonburg, Kentucky.
Okay.
Yeah. And the other was in Flatwood. So I've done some oral health education around the state with your diabetes or the community health workers.
Yeah.
Yeah. So I'm not sure if there are any community health workers that are on this call today, but it's definitely a group that I'm familiar with. And I say all that to say, when I've done these trainings in the past, they're normally like 3 hours or half a day trainings. And we're going to try to fly through some of this material in about 30, 40 minutes or so, but it's okay. I mean, if we need to do a take 2, you do part 1 and oral health part 2, that's fine as well. Cause I do want to take time to hear from you all. So basic kind of high level, I might have to reduce my screen here so I can look at my own words. Kind of our session objectives this afternoon with our virtual office hours. We want to look at evidence-based association between oral health and diabetes, and for sure it's a bidirectional association. We want to illustrate the significance of oral health as an important component of diabetes management. I definitely want to hear from you all to gain your thoughts of if you are incorporating oral health and diabetes management. Is it become an important part? If yes, why did you choose to incorporate it? How did you choose to incorporate it? If not, why not? Which is absolutely a-okay as well. We want to look at some oral health resources. Are you using any oral health resources? What's missing? I'm going to try to put you back on there so I can see you all. What's missing? And then we want to look at some strategies. Do you have any strategies in place that you're engaging your clients with? Do you have a need for additional strategies? So kind of basically what's working for you and what's not working for you. And I say all that to say too, that I'm definitely a resource. Please don't think this is just a one and done presentation. Our team at Marshall is here for you around supporting you with your endeavors of incorporating oral health into your outcomes, into your your patient education. So I kind of want to cover this slide as a grounding slide. There's a couple that are really key in these messages, and the first is this slide that you're looking at right now, and it's an older slide, and it comes from the United States Surgeon General's report that he authored in the year 2000, and basically it was a real monumental report because it put oral health it put the mouth back in the body. It just really called attention to the fact that, hey, oral health, oral disease is not standalone. If you have oral infection, oral disease, it impacts diabetes, it impacts were dental cavities and periodontal disease. And that's kind of some old-fashioned terms are gum disease or pyorrhea. Those are more old-fashioned terms, but regardless, both of them are preventable diseases. So periodontal disease, which the end result is tooth loss, and dental cavities, so dental caries. And, oh, I'm not going to go back to that slide, but I will tell you another of the really stark statistics highlighted in the Surgeon General's report was adults miss more. This is, I mean, it's craziness to think of this. Adults miss 164 million work hours across the nation due to dental related illness. That is a lot of productivity down the crapper because of poor oral health, you know, whether it's a toothache or dental infection in their mouth. So when we look at optimal oral health, this is kind of what we want to see in the mouths of our patients or clients, whatever terminology you use. You can see nice pink healthy tissues. The teeth are free from decay. Everything looks nice and healthy. And when we progress on, we talk about the next step of the disease process called gingivitis. And when I'm doing this course live, this is when I walk up to the screen and I put my fingers over an individual's kind of like this, and you only see the bottom, you know, you only see the tips of the teeth, like the 1/3 portion of the teeth. So if you're talking to your patients and clients, unless you do what we call lift the lip and look into their mouth, you're not going to see this. What you might pick up with periodontal disease, when we get to that on the next slide, is a very bad smell. And that's what I put here on the second bullet, the bacteria that cause this. The bacteria that cause gum disease have a really strong odor. And I'm not sure if you've smelled that before or not, but it's just kind of one of the tall tale signs that, you know, there's an infection going on in your patient, your client's mouth. So with gingivitis, it can be reversible. This condition that you're looking at on the screen can be reversible. It takes about 7 to 10 days of really good brushing and flossing and an antimicrobial mouth rinse to reverse this. And then when we get on to gum disease, which you see there, that's when you start looking at irreversible damage. With the gum tissues, you can see now the gums, if you look at this slide, the picture here, you can see how the teeth look longer. Do you all see that? Yeah, thumbs up on seeing how the teeth look longer. Yeah, that doesn't grow back. And then I want to show you some x-rays of what this particular bacteria does to the bone as well. So I say that so you can understand like the significance of the infection in the mouth. It can be a really aggressive infection, and it, again, think back to that grounding slide of the Surgeon General's report. That infection does not stay stationary in the mouth. When we'll talk a little bit about the bidirectional relationship between poor glycemic control and rampant gum disease, or even infection with decay, dental decay. So periodontal disease can be controlled. It can be halted, but gum tissue and bone tissue do not grow back. All right, so when you look at how in the world do we get from healthy, like you see on the left-hand side of your screen, to this disease state, you have to remember too, periodontal disease is very asymptomatic. It's kind of like heart disease. People don't know that they have an issue until they have a heart attack and they're like, oh crap, where'd that come from? It's the same way with periodontal disease. It's very sneaky, very asymptomatic. So some of the things patients may or may not kind of fuss about or bring to your attention, there might be bleeding gums, and it's really amazing when you talk to, I know my 15 years in private practice, when you patients, you're cleaning teeth and their, their gums are bleeding everywhere, and you're like, this is going on at home. And that's so common for them to have a pink toothbrush. They're brushing their teeth, spitting in the sink, and they're spitting blood, but it's just so common. It's so common for them. They don't think anything about it. But I always kind of use this analogy. If you went to the sink and washed your hands and your hands started bleeding, would that not freak you out? Yeah, that would freak you out. There's clearly something wrong. If you're brushing your teeth and flossing your teeth and your gums are bleeding, there is clearly something wrong. There is an active infection going on in your mouth that needs to get under control. And that's especially important with those individuals that have diabetes. We do not want any infection going unchecked at all. So the fancy words for erythematous, edematous are just swollen tissues, red tissues. On the picture on the right-hand side, you can see receding soft tissues. You can see, like I pointed out before, how the teeth actually look longer. And again, that tissue does not grow back. You can see, and I know some of this is a little bit yucko around lunch, and I'm sorry, but you can have pus or infection in the gums, in the teeth. Halitosis is just the fancy word for bad breath. Mobility means, if a patient would ever say, hey, Sheila, is this normal for my tooth to, look at how loose my tooth is. So that tooth is mobile, that tooth is loose. And that's automatically going to cue you into, oh my, they have infection or they have advanced periodontal disease. Because again, think of those pictures I showed you where right here, you can see how the gum tissues recede and the bone is destroyed as well with periodontal disease. So, and it makes the teeth loose, and ultimately the teeth will fall out. So it's going to change, changes in occlusion. That's just the fancy word for how the teeth come together. Changes in the fit of partials, dentures, or bridges as well. And then here we go. Here are the pictures of the x-rays. So 1, 2, 3 on the screen here, you can see healthy bone level is up around the necks of the teeth where the line is. That's where the bone level should be. So when you go have your x-rays taken once a year in the dental office, that's where we want the bone level to be. Moderate bone loss, you can see the yellow line, how the bone is dropping down. And this is all from periodontal disease. This is all from gum infection. And then you can see severe bone loss on the third picture with the yellow line. And that would be a patient, if I had that patient in the chair and I was to take those bicuspid teeth and I would move them or try to move them, they're going to wiggle around. They've had so much bone destruction that those teeth are loose. And if we don't get it under control, the next stop is, the teeth are going to need extracted. But there's a lot of bacteria around that causing infection. Okay, this, if I had to, the Surgeon General's slide is super important. This slide is number 2 on the list. The big takeaway from this particular slide is you can see we have about 3 centimeters of ulcerated tissue. There is no way in God's green earth that if a patient would ever show you this, a patient or a client, that you would not make a referral or do something about it. Is that right? No way. You would not let that go unchecked. There's more ulcerated tissue with periodontal disease than you see with the ulcer on the foot. But again, if you're not lifting the lip, if you're not, kind of cueing into, okay, when you're doing that head to toe assessment with your patients that have diabetes, if you're not looking at oral health and they've got, you're trying to manage everything else and they've got the poor glycemic control, this could be your missing factor right here. It could be periodontal disease or gum disease that's just gone unchecked. Now, I do want to kind of transition into some of some of the kind of the visual science behind this, the bidirectional relationship, but I want to talk about some of the numbers behind it. And this data, I really dislike using data that's older than 5 years old. And I do realize this is older than 5 years old, but the statistics are pretty much still the same. So we know that about 50% of adults age 30 and older have some form of gum disease. The risk of periodontal disease is 2 to 3 times higher with those individuals with diabetes. And about 1/3 of people with diabetes, with severe diabetes have, 1/3 of people with diabetes have severe periodontal disease. So whether you know it or not, it's definitely impacting the patients and the clients that your coalitions are targeting for better health outcomes. And I would really hope, thinking back to that second slide of all the pictures with the coalitions that we've done trainings with, I would hope that instead of 85% of this statistic here, and this is CDC data, it says 85% of patients with type 2 diabetes report they have received no information on the association between diabetes and oral health. I would hope for our group it would be 0%, because I would hope everybody has received information on oral health and diabetes. And if not, we'll save time at the end of this particular, interactive session to figure out how we can do that, because we want everybody to have that information. It's out there, and I really think that we can tailor it to each of your coalition's needs. So kind of diving further into this bidirectional relationship, we know periodontal disease affects diabetes and poor glycemic control, but you can see here now the bidirectional flow of diabetes can increase the risk of periodontal disease as well. So it doesn't state these two systems interact. They don't stay independent one of the other. Okay, so which comes first, the chicken or the egg? First I ate the chicken, then I ate its egg. So it's kind of looking at this paradox between the egg and the chicken. Periodontal disease may worsen glycemic control, and then poor glycemic control may make controlling of periodontal disease more difficult. Okay, this would be the third slide. If I would say, Jan, you asked if you could have this, and Sue, I think Sue too, if you could have this presentation and you print this out, I would circle that oral health, the Surgeon General's report. And then this is another one that I would circle. This is such a big one. And this was a lot of conversation around this when I did the training with the community health workers. We want to talk about breaking, how in the world do we break this cycle? So poor periodontal disease worsens glycemic control. Then looking at the second little bubble here, patients with periodontal disease are twice as likely to develop diabetes. Then the third bubble, poor glycemic control is associated with a 3-fold increased risk of periodontal disease. And then the green square kind of is like the money shot right there. Treatment of periodontal disease results in 10 to 20% improvement in glycemic control. That is really ginormous. I don't have to tell you all that. You know better than I, that's really big for individuals that are affected with diabetes. So that again could be, why they can't get things under control, is because they have active infection going on in their mouth. So real quickly, I'm trying to keep an eye on the time too. It's already 12:30. I knew this would go fast. There are also some other oral manifestations I just want you to be aware of when it comes to oral health and diabetes. And there's an increase in caries. And again, that's the fancy smancy word for cavities. There's a predisposition for xerostomia. That's the fancy smancy word for dry mouth. And a lot of individuals that have diabetes have dry mouth, and it could be because of a lot of the medications that they're on. They also can be affected with frequent abscesses, which is never a good thing. Active infection in the mouth is definitely not something that we want to see. And they're also predisposed to fungal infections. So you perhaps have heard of thrush or candida. That can be something that creeps up on them as well. Okay, so when we look at caries, cavities, this is what it looks like. This was one of my patients actually on the upper left-hand side. And then I'm going to talk about the role of his diet, how he got to where he did, because it was very much diet controlled. But I want you to understand that that cavities is a bacterial infection. So when you have a tooth that's been affected with dental decay, it does not go away. It's not like a common cold. It doesn't go away. Actually, that bacteria spreads. You know, we all have saliva in our mouth. That bacteria can spread through saliva. So you can see all of his teeth just right across the anteriors. All of them are just zapped with dental decay. Regina put hot, I think she put hot mess hair on her little name thing. He has a hot mess decay party going on in his mouth. Okay, so what are the result? What can we expect, or what can you expect with untreated decay if you have patients that are in your patients' clients? I don't know. What do you say? What do you call your folks in your coalitions? Patients or clients?
Participants or community members, that's what I call them.
Okay, thank you for that. Participants or community members, gotcha. So if you have participants or community members that are doing, that you're engaging in outreach, what are some of the things that they might, if they have, unchecked dental decay, that they might be fussing with or complaining about, or just mentioning to you? It can cause extreme pain, and within all those little teeth are little nerves, and they can yield big pain and big infection. Yes.
So I have a question. I know in a lot of rural communities, we don't have a lot of like free dental care, and dental care is very expensive. And when you have something like Medicaid or Medicare, I'm not sure if do they cover like the treatment of periodontal disease?
We are going to get to that. I'll put that. That's an excellent question, and one that we can probably spend, a whole second session on talking about, like with barriers to care, how you're going to access, indeed, if you do have a participant that says, hey, Regina, I have a toothache, you're going to want to know where to send them.
Mm-hmm.
You're going to want to be like a referral source for them. So, we kind of have to have those conversations with dentists in our area, identify resources in your area, and then figure out if they're an adult, what kind of coverage they have or they don't have. So, but we'll get to that a little later on. That's, okay. That in question is just as important as all of this. And I'll keep an eye on the time. So extreme pain, spread of infection. Again, that bacteria, the infection doesn't stay stationary in the mouth. It can access the bloodstream and spread to the heart, affect other systems. And as Regina mentioned, it can become very costly. So you can look at a tooth, if the participant, if they had just what we call one surface cavity, you can look at, something that costs $70 to fix if you catch it early, versus an abscess tooth that might require a root canal and a crown, that then you're looking at thousands of dollars, or, they might opt to have the tooth extracted. So, we want to catch everything as early as possible to avoid, those $1,000 price tag treatment plans that are fun for no one. Okay. So I'm really going to zip through this through all of these next few slides, because I can already tell I'm talking way too much, and I'm never going to get to the end. And I really trimmed this down. Shucks. Oh boy, that's okay. We want to talk about the dental decay process, what kind of messages that you have for your participants or your community folks, and then ideas for patient engagement. So let me just kind of zing through these really quickly. And I know I'm going at lightning speed, but the big takeaway message here is we are not born with the decay causing bacteria in our mouth. We get that from your mama, or the primary caregiver. So I have one slide that has a mom holding a newborn, and she has a baby bottle of milk in the newborn's mouth, and the infant's hand is in mom's mouth. And I always ask, where's the infant's hands going next? And in their mouth. They're going to put it in their mouth. That's how the bacteria that cause decay, that's how it's transferable. So it's transferable from the primary caregiver or the mom to the child. So they are born without it, which is really interesting. Okay, so once you have that bacteria in your mouth, it eats, you know, we love fermentable carbohydrates. It eats all of that. Gosh, sorry about this, you all. Like, I'm trying to click through these as fast as possible. And then it spits out an acid. So you've all had a chance to have breakfast or lunch. And when I do this training live, I have everybody take their tongue and run their tongue over their teeth, and you can feel how your teeth feel kind of fuzzy, like they're growing fur or wearing socks. That is just a orobiofilm that's in your mouth. And so that's where all those bacteria are, is in that, you know, matrix of biofilm. And then you feed it. Like I'm feeding that with, I love these things, whatever these little gingerbread crackers are, but they're, you know, they're fermentable carbs, and I'm eating that, feeding those germs, and then it shoots out an acid. Well, the acid attacks the tooth for 20 minutes. And you might remember some of those old commercials that said, you know, for chewing gum, if you can't brush or rinse, chew gum for 20 minutes after you eat. Well, the whole intent, impetus behind that was to increase salivary function. So you're neutralizing all of the acid that's in your mouth. So that there really is a lot of truth into that. Okay, so what does it look like? You know, teeth always decay from the outside in. You know, I have patients, many patients that would say my tooth I just bit on something and my tooth fell apart. It decayed from the inside out. Heck to the no, it didn't. It's what you ate and drank and how the tooth broke down. That's how it happens. Oh, but I meant to tell you, by the time this little white shell on the outside, by the time if decay from the little black blob that you see right there, by the time it breaks through the enamel and hits the orange part of the tooth, that's the nerve, you're going to absolutely, Regina hit the nail on the head. You're going to have a big, massive toothache, and that is no fun. And that's when you're going to need to have that referral system, Regina, in place, because those calls people don't want to hear. It's going to take 2 weeks to get into a dentist if they call you with an abscessed tooth or a toothache. So this slide is a little bit busy, but to break it down is every time you eat a fermentable, you know, every time you're feeding that bacteria, and I've got like the worst things beside me today, you guys. I've got like this Gatorade that's loaded with sugar. Geez, I'm not a very good role model for you all today. I normally am, but every time you eat that, it produces acid for 20 minutes. So if I have this and I'm snacking on this, I'm drinking this all day, it's gonna wear my teeth down. It's gonna produce a constant acid attack on my teeth. And I told you I'd share with you what happened to my patient on the left-hand side of the slide with all of the pictures. Whoops, sorry, my doggy. With my with dental decay, he could, for the life, he could not figure out why his teeth decayed like that. And he was a truck driver. And so we went through, you know, he was like, I'm brushing my teeth. I'm like, all right, I'm flossing my teeth. And I'm like, well, what are you doing? Like, what are you eating and drinking during the day? Mountain Dew all the time. A big thing of Mountain Dew. He just drank Mountain Dew all day long. And that acid just wore the enamel right off of his teeth. He ended up losing most of his upper teeth. We were able to get a partial for him, but he lost most of them. Okay, so I have 20 till. Oh my goodness. This is something you inform your participants about, your folks in the community, the importance of, you could teach this better than I, eating healthy and nutritious meals. The one thing I'll point out to you on the bottom, the fourth bullet, is the importance of drinking fluoridated water. It'd probably be advantageous to, you know, kind of figure out if your communities have fluoridated water, because Regina, if adults don't have any form of dental coverage, preventive care at all, fluoridated water is the one thing that they have going for them. And community water fluoridation reduces dental decay in both children and adults by 25% just by drinking water, fluoridated water. Isn't that amazing? So community water fluoridation is one of those, frontline public health achievements that we want to protect at all cost. So if you're talking to your participants about the importance of drinking water, it's better for them to drink water, clean water from the tap that's fluoridated than bottled water. Okay, moving on. So I'm going to fly through this so we can talk, or I'm never going to have an opportunity to hear from you all. So some of the strategies that you can, talk to your coalition participants about, basic brushing, basically basic brushing and flossing methods. Making sure that they're using a soft bristled toothbrush to brush their teeth with. I like to say change your toothbrush with every season. So make sure you change your toothbrush every 3 months. If you get a cold or a flu, throw your toothbrush away because bacteria can live in the bristles of the toothbrush and you can reinfect yourself. So throw your toothbrush away. So make sure you're using fluoridated toothpaste, a soft bristled toothbrush. If your toothbrush looks like this second picture that I'm kind of like swirling, I don't know if you can see that I'm swirling my cursor around that. If it's, it's frayed out like that, throw it away. It's absolutely of no use at all. And then make sure you're brushing your tongue, because if you ever stick out your tongue and your tongue is white or yellow, or I've seen tongues turn all kinds of colors, it's just coated with bacteria. And you can see here a little picture. I don't know if you can see me swirling my cursor around that or not. That's a tongue scraper, and I give those away. What I do, yeah, very good. You get a gold star. Nice pink tongue. Those plaques or the tongue scrapers are awesome. They just remove all of the bacteria, the plaque, right off of your tongue, and it's harder for some people to use them first thing in the morning. Like I always share this when I do trainings, like my husband will be using his tongue deplacker and I'll hear like, what in the world? It triggers a really prominent gag reflex in some people. So you might not want to do it first thing in the morning, kind of do it. Yeah. Oh, Sheila has that problem. Yeah. Do it in the evening, and then your gag reflex kind of settles down. It's less prominent in the evening. So, and then there's all kinds of tricks to the trade when you look at, if you have participants that have, decreased manual dexterity and they need to alter the toothbrush. If they're having problems brushing their teeth, you can see some of the pictures on the lower right-hand side. You can put like a bicycle grip on it. You can put a tennis ball on the end of it to help them grip the toothbrush better. And flossing is always a good idea. I tell people your teeth have 5 sides. The outside you see, the inside that you feel with your tongue, that's side number 2. Inside, outside, side number 3 is the part that you chew with, the tops of your teeth. Side 4 and 5 are in between. So your toothbrushing only gets side 1, 2, and 3. If you're not flossing, you're never cleaning side 4 and 5. And then that'll lead to decay and gum disease. And mouth rinses are fabulous as well. We just want to make sure with your participants that might be experiencing xerostomia or dry mouth, for them to stay away from mouth rinses that have alcohol, because that would further dry out their mouth. Okay. I think I'm kind of going to, if it's okay with you, Sheila and Regina, I'm just going to skip through these so we can spend some time talking.
Sure, I'm sure everyone has lots of questions.
I'll just show you some of the pictures of xerostomia and kind of what it might look like. But here we go. Some of the things that you might hear from your participants. My mouth is really dry all the time. I have to keep water with me all the time, or I have a burning sensation in my mouth, or my tongue burns. I have to, again, drink liquids throughout the day. The goal with managing xerostomia with dry mouth is to increase the salivary function. So you can do that with sugar-free gum, sugar-free hard candies, There's a line of product called Biotine that I'm sure you've seen in the pharmacy that is excellent for helping with dry mouth. Oh, there it is. I forgot to put a picture of it. And then the other thing is if they have natural teeth and they don't have full dentures, an electric toothbrush will actually increase and stimulate salivary flow. So that would be a very good recommendation as well. Okay, frequent abscesses, we talked about that already, that diabetes does indeed alter the response of the periodontal tissues. And you can see here, I know that some of that stuff is hard to look at, especially if you have a weak stomach, you're not used to this. It's hard, I know. But you can see here, I told you there can be an presence of pus, you know, and you might there might be a time that you have a participant or a client that, you know, says, look at this, what do you think this is? And pushes down on their gum tissue and they have like kind of pus that shoots out. And then you're like, whoa, okay, we need to get you to the dentist. There's an active infection going on in your mouth. Okay, here's a picture of Candida, or what we call thrush. So we do know from the science, and this is from data from the Centers for Disease Control and Prevention, that diabetes is one of the risk factors for that as well. And you know that stuff travels, right? It can travel, it's bidirectional as well. It can travel from the gut up or from the mouth down. Okay, here we go. This is the part that I really wanted to hear from you all. So strategies to achieve and maintain good oral health, including oral health messaging in your home visits, using motivational interviewing, which I'm sure you all are more of the experts of motivational interviewing than I, but I do want to show you one resource that I really like. And hopefully some of you are using it, I hope. Okay, so this is kind of an older program. This is from the CDC as well. And this is called, it makes me laugh every time I say that, the PPOD Toolkit. I don't know if you've heard of it or not, but it's pharmacy, podiatry, optometry, and dentistry. And then it just gives very bulleted messages that you can talk to your participants about, like visiting your dental provider at least once a year for a full mouth exam, learning the best way to brush your teeth and dental floss, asking about the early signs of tooth, mouth, and gum problems, and then the association between gum disease and diabetes. So that's one free handout that's out there. I wanted to bring that to your attention. All of these handouts, you all that you see on the screen, those are all free. So some of them are from the Centers for Disease Control. Others are from the National Institute of Dental and Craniofacial Research. But this one in the middle, I know Sheila and Regina have seen, I'm pretty sure you all have seen that one. That's my favorite one. And it's free. On the back of it, it has questions that your community health workers, or you can have folks kind of check off, and it gives them goals. When you look at weaving in motivational interviewing components of, just you never ask, do you have a dentist yet? Yes or no. Don't ask those questions that are just, dichotomous variables of yes or no. You want to say, when's the last time you went to the dentist, or tell me a little bit about what's going on in your mouth. This middle handout is the best oh gosh, here you are. It's right there. I took a picture of the back of it. No, right there, your to-do list for healthy teeth. So they can goal set is what I'm getting at. They can goal, you can do some goal management with them, which is awesome. And this is another, I like it handout as well that you can use. This is kind of the head to toe checklist, and it has one for your mouth, for the client's mouth, and it's on the bottom. So they could take that with them to the dental office, and the dentist, dental hygienist would help fill this out. And all those things that are risk factors that we just talked about, like xerostomia, fungal infection, parotid gland changes, that's one of the glands that pumps out all the saliva. Have they had any changes with that? They can fill out this form and then bring back to their PCP, their primary care provider, and then that kind of clues them in if they need treatment with their oral dentition, with their mouth. I love that handout. So you might too, or you might not. So I'm okay with either way. So key questions that you can ask your participants. Do you visit a dental provider at least once a year for a full mouth exam? Do you know how diabetes can affect your teeth and gums? You know, if so, tell me about it. You know, you want to hear them kind of do that teach back and, you know, hear kind of where they are in terms of their knowledge. And then what are the early signs of tooth, mouth, and gum problems? Okay, Regina, to your point here earlier, to your question earlier, we want to help them find a dental home. We want them to have an ongoing source of dental care. We just don't want them to be scrabbling to find a dentist if they have a toothache or a gum ache or a black spot, you know, pop up on their tooth. Okay, if find out why follow-up care or treatment is not complete, if they have, you know, an issue, what is it? Is it a financial barrier? Is it a transportation barrier? Are they scared to death? Because dental phobia is alive and well. A lot of patients are, you know, they've had really bad experiences as children that they've carried on into adulthood, that they're just scared to death of the dentist. You know, is it cultural or linguistic issues? And then here we go. So locating oral health professionals. So you want to make sure that before you have those conversations with your participants, that you know where the community clinics are. You know, where are they in Boone County? Are there any in Boone County? Are there any federally qualified health centers in Boone County, or where are they in Mississippi? Or, you know, you kind of have to identify them and have that referral source. You know, where are the dental schools located? Can you make referrals to dental schools? Do they have an emergency clinic that your patients can walk into? We are really fortunate, and you can see here at Marshall, we have a partnership with HealthRight, that we have a mobile unit that travels around the state of West Virginia that will see, that would see your participants, which is great. And then tapping into the Free Clinic Association. All right, and then strategies to incorporate in your, I didn't change that slide, I'm sure, sorry. I put into the outreach of community health workers, but into your coalitions. I'm sorry about that. So there's dining with diabetes programs. I know we have that in West Virginia. I'm not sure if that's, you know, within this whole consortium, if you have that. Developing a dental referral catalog, making sure that oral health is represented at your health fairs. And then kind of taking this to the next step, if you are interested in learning more about oral health education and how it affects overall health, there is a national curriculum that is fantastic. It's called Smiles for Life. And this, over the last 2 years, they've added new modules. In course number 10 is for community health workers. So you all would be interested in that as well. And it's free, which is fabulous. And if you are, I think someone might have said I think someone said in their intro, they might've been a retired educator, or if you're a retired social worker, nurse, or whatnot, and you're keeping up your license, this offers free continuing education, which is fabulous. Ha! I did it. 5 minutes to go. That's not a lot of time for questions. Eek! But I'm happy to take any.
Any questions for Gina? You can unmute yourself, or you can put it in the chat box.
That was a very high level overview of oral health and diabetes connection. And it might take might take a while to process that, all of that. That was kind of rapid fire. Like I said, when I do this training with community health workers, it's like half a day.
I think it was all useful information, good information that if we could break it down into more manageable pieces that we can give out to our community members. So I enjoyed it, and I learned several new things that I didn't know.
Oh, thank you for your kind words.
Yeah.
So Gina, I have a question.
Yeah, Janice.
My question is, are we free to go back and share this with people in our communities? Do we need to have training for this, or we can use it as is?
I think you can use it as is if you're comfortable with it. And if you want to, learn more, like I was sharing with that Smiles for Life module, it breaks it down, like Regina said, to more manageable bites that you can kind of process, on your, as you, at your leisure.
So you can use either one.
You sure can.
Okay.
You sure can. A lot of, most of the information, if not all of it, is very much congruent.
Okay.
Yeah.
I like several of the slides. I think they would be good resources to put on our Facebook pages and things like that to get the word, spread the word more. We don't do a lot with dental in our coalition, so I'm anxious to get the PDF slides. And I think the resources that you shared, we're trying to do a little campaign to improve our Facebook presence, and we're doing one day for nutrition, one day for physical activity, and then one day for resources. So these will be wonderful to use on that third day of the week that we are trying to ramp up our Facebook to use those resources. So I appreciate those.
Thank you, Debbie. I appreciate those comments. And one thing that I did fail to mention for West Virginia folks, we had a major win in the legislature this past year where we had worked for a decade, 10 years on trying to get a dental benefit for adults that are covered by West Virginia Medicaid. All they had was basic emergency, they would pull a tooth basically if they were covered by Medicaid. So this year we were able to pass legislation that they now, as of January 1st, 2021, they will have a benefit of $1,000 per year that covers both preventive and restorative care. So that was, I know that came up at every training with the community health workers as to what about the folks that are covered by Medicaid? What kind of benefits do they have? And it was very different in Kentucky versus West Virginia at the time. So I'm glad to say and glad to report that's happening here soon, coming January 1. And I'm not sure about Mississippi. I didn't do my homework there.
And then
I'm sorry, Regina.
I'd just like to share another resource, those flyers from the National Diabetes Education Program. I know in Alabama, the state health department will send you those flyers for free. So if you can check with your state health department, they may have already, free resources that they could share with your coalition. And
That's fantastic.
And another thing, when I was a lifestyle coach for the DPP program, a fellow lifestyle coach used to work for Delta Dental, and she was able to get us like 200 free toothbrushes. So I would definitely reach out to them to see if they would donate toothbrushes or toothpaste to your coalition.
Mm-hmm.
And Gina, I have a question too. I love your presentations. Every chance I've got, when you guys used to come to the coalition conference in Gatlinburg, I always thought they were great.
Thank you.
But the training modules for the Smiles for Life,
Yes.
is that something that you would do for lay leaders?
I could.
Uh-huh. I was just thinking that would be a resource that perhaps our coalition members could be trained, to deliver.
Mm-hmm.
And I think it would be, you guys tell me, Debbie, Carolyn, Janice, Sue, what do you all think about that?
I think so.
Should you guys be interested in a training module like the ones for the Smile for Life so that you can share it with your community?
Yes.
I think that would be very helpful. Yeah.
Awesome. Okay. How How long is that training, Gina?
It takes about an hour to work through.
Okay, all right. We'll be following up with you. If you don't mind.
No, I don't mind at all. I kind of thought there might be a part two.
Yeah. Thank you very much.
You're welcome.
And then Jan had a comment. She asked if everyone had a RAM, has a RAM clinic. I think those are the free clinics. They have like different types of screenings. I know we had one in Alabama, but I only know of one event they had that was pre-COVID.
Yeah.
And those are important events, but man, that's a far cry from what we want to see in terms of a regular source. It's not a regular source of dental care. And if you're not familiar with RAM, it's a remote area medical, kind of like a MASH unit where folks come in and provide care for 1 or 2 days, and we also term them missions of mercy. We've had a couple of those in West Virginia. So you have the RAM project and the Mission of Mercy, and I'm telling you, if you've not seen them, they're really they do tremendous work, but it's also very heartbreaking because folks will line up. I've participated in a couple, and the last one I remember in Martinsburg, when I came in for the training, I had to drive, 3 hours to the Eastern Panhandle. I came out of my training that started in the evening, and I think we came out at like 7:30 at night, and people were already lining up that night, and the clinic didn't open until like 6 in the morning. So they stand in line, they sleep in line, they get one service. So you can pick one service, to get a tooth taken out, to kind of like with RAM as well, you can get your eyes checked or new glasses or whatnot, but it's not a regular delivery of care. But they can be if they're in your town, and that they're there. You can definitely make referrals to your participants. Some care is better than no care. I'll put it that way.
Absolutely. Any other questions for Gina? We can certainly, if you want to, what's your email address? I'll put it in the chat box. You can say it, and then people can follow up with you directly.
How about that?
There you go.